All right. At the outset, I must thank the JICS organizing committee for having invited me to this great scientific exhibition, and thank you, Chairman, for having accommodated me a talk earlier. Well, 1964 was the time when septic shock started getting a lot of publications up. Canadian Medical Journal, many other journals started publishing about septic shock per se, and it was at the same time that Henry Stewart, this person is a Supreme Court advocate in US, said, I know it when I can see it. And I'm certain that every person sitting in this audience doesn't need a definition for sepsis. I mean, every one of us can actually look at sepsis and figure out this is sepsis per se. Well, the crude mortality of sepsis still remains very, very high, and it is around 30% in most of the countries all around the place. What you see in blue there is those countries in which the incidence of sepsis is very, very high, and India stands in one of those. And on the other side of the slide, what you see is deaths due to sepsis. Remember, this 4.5 to 6 million people are dying every year due to sepsis per se, and this is much more than myocardial infarctions and strokes. So definitely sepsis is a killer disease is what it looks like. Well, what we thought for a long period of time, was sepsis is just an excess inflammatory immune response. This is what I was taught, this is what I thought, and this is what we did for a long, long period of time. That's why many therapies were actually used to target this particular anomaly that was there. But now we know it's definitely very, very complex, much more complex than we thought about. In fact, immune response per se, immune response is actually very, very well balanced. It is actually very, very well regulated. But when it comes to sepsis, the entire thing is extremely dysregulated. It is dysregulated reaction is what we put it as. Now, if I go a little bit into theory, this particular this sepsis is a very highly individualized process, which actually depends on the immune status of an individual. This per se is dependent on factors such as age, comorbidities, environmental factors, microbiome, and stuff like that. More importantly, each individual is characterized by a highly complex set of genetic polymorphisms and epigenetic modifications, making it a very unique selection of high or low responder states encoding cytokines that may cause the patient to go down or may cause the patient to go up. This is what is regulating your immune response. Well, it has got a hot part and a cold part, which we call as the pro-inflammatory and the anti-inflammatory kind of situation. Well, it is regulated by PAMs, that's the pathogen-associated molecular patterns, which thus incite the coagulation system complements and the endotheliitis that we call about to cause a microcirculatory disorder. And then this causes tissue damage, thus elucidating the advent of damage-associated molecular patterns, then causing neutrophil extracellular traps and causing inflammation-associated death called as pyroptosis. Well, the other side of the story is that there are anti-inflammatory cytokines. These are cytokines that are actually coming together. We initially thought there was a SIRS and a CARS, but now we know there's SIRS and CARS that come together. And at the same time, you have anti-inflammatory cells per se that actually causes T cells, B cells, dendritic cells, apoptosis. More importantly, there is these MDSC cells, suppressor cells that are kind of increasing the regulatory T cells also. And this immune suppression is kind of amplified by reduced expression of HLA-DR. All these are targets. Remember these. All these are targets which will probably be used when we are looking for cures in these cases. These all lead to actually programmed cell death, and that's what you're seeing, programmed cell death. What happens is an extreme complex reprogramming of our immune cells is what it appears. Well, if this you thought was complex, this is more complex. So this is actually what sepsis is all about. It is so difficult to target one particular element out of all these things. So we all agree to the fact that it's complex, and we know right from the time sepsis has come in. What you see on the left side is the US database, which actually shows that the mortality hasn't changed much. On the top, you see Japanese mortality actually coming down a little bit, but really not as convincing as what you see in myocardial infarction. Look at myocardial infarction. What mortality it had and where it came down. This says that sepsis mortality has definitely not changed tremendously. This is very clear. Among all the diseases, I think this is one case where mortality has not changed. Yes, we are doing fluid resuscitation. Yes, we are giving antibiotics. Yes, we are giving superventilation. But then mortality should have drastically come down, isn't it? No, but we are looking for answers. Basically, we are still looking for answers. We still don't know the drug that we should be using to get rid of this sepsis. And yes, no topic is complete without we talking about COVID. And really, COVID is something that has taught us a lot of other things apart from friendship among colleagues. It has taught us to be the big bounce back of actually immune modulators. This is what has occurred with COVID. COVID has actually taught us all about immune modulation. Right from the time we started toying around with tocilizumab, the recovery trial, and WHO actually pre-qualified the first monoclonal antibody to treat COVID-19, we realized that COVID is nothing but a certain form of sepsis, a certain form of viral sepsis, or a dysregulated immune system. And that's the reason that I'm very fortunate to have been part of this particular trial that was published in JAMA. And we thought steroids would be the right way to go. Yes, we proved the fact, and yes, steroid becomes folklore. Steroid is just one cog in the wheel of immune regulation is what it appears. And what was happening at animal kingdom at that time? At that time, there were beautiful studies actually coming out. One of these being this one. So interferon beta was actually given to a cecal ligation rat model. And this is actual sepsis. You know, when you ligate a cecum and you puncture it, you get sepsis. And they gave it before the cascade of sepsis started taking place. And what did they find? They found out those rats that were given interferon beta, they actually started getting better much quicker than any of the rest of these rats which were not given interferon beta. Phagocytosis improved. There you have something that is modifying the disease now. Well, this is food for thought, definitely. So when I go back to my mitigation of sepsis, I feel if we probably get off this by, say, some kind of molecules that are coming in, and if I come off this by, say, some other molecules that are coming in, that means it requires a whole basket of equipments, of drugs, then probably we may be able to mitigate sepsis is what it appears. So maybe we need something more in the usual management of sepsis. This is what it feels like. There's a whole bunch that has been talked about, urinastatin, thymosin alpha. We all use so much of this all the time. And I'll probably just show you etolisizumab because it kind of represents more than what everything does. It does drop the CRP, it does drop the D-dimer, it does drop the LDH, it does drop the serum ferritin. This is very clear with most of these drugs. Whether it changes mortality is a whole different ballgame, but it does do something to these particular inflammatory markers is what it appears. Very small data. The data is so abysmal that you have barely small case reports that come out that say that there is some kind of improvement in inflammatory markers. Data from Cuba also came out which actually showed the Apache scores actually coming down, the SOFA scores coming down. Well, the problem with sepsis is it's actually a complete graveyard of clinical trials. We have so much negative clinical trials that we are still waiting for answers, and I hope answers come out very quickly. Yes, data is wanting. Sepsis is complex. It's a deadly immune reaction. Yes, we are actually hunting for answers. Maybe immunomodulation is one of those. Thank you very much.